Good afternoon. Thank you for joining us today for Early Childhood Workforce, supporting the professionals who support our families. I am Megan Carolan, the Vice President of Research at the Institute for Child Success, and I'm pleased today to be presenting with my co-author and colleague, Amber Posey. A few logistics notes as we begin, and if you've been with us all day, you have heard some of these already. The session is being recorded and the chat is being archived. Attendees are in view-only mode, so you cannot use your microphone. We encourage you to use the chat box throughout the session to engage with the group. What we'll do today is go right through the presentation straight and then take some questions and answers. We have a good chunk of time at the end we'll be able to use. So feel free to keep those going as you think of them, and we'll loop back around them at the end. This session does use auto captioning. If you would like to activate these, look for an option on your toolbar that says live transcript and select either subtitle or full transcript. If you are intending to claim professional development credit through SC Endeavors for Early Educators, please use the link that we're about to share in the chat box to register your attendance here today. These sessions are also eligible for CME credits. Further information, including the link to complete your attestation form, will be sent in a follow-up email very soon. For all other professionals seeking professional development credit, please reach out to us by email and we can generate a certificate to verify your attendance and file with your governing board. At this point, you can also return to the lobby at the end of this session. This is our last session of the day, but the lobby will be open for your ongoing questions. At this point, let's go ahead and get started.
Thanks for joining us today for this conversation about the early childhood workforce, supporting the professionals who support our families. If you're here, the chances are good that you are already very interested in this topic, perhaps a member of the early childhood workforce, managing a program or working maybe in some policy areas that have implications for this workforce. The most important thing to level set going into this conversation today is that we really want to broaden out the definition of what we mean by the early childhood workforce. Traditionally, it's a term that's used to talk about early childhood education and care providers. Even then, it's sometimes not a broad enough umbrella to really capture the full range of settings and home-based and provider types. But we want to take this out even further now. In this presentation today, when we're saying early childhood workforce, we are meaning a range of healthcare, child welfare, education, and care professionals, all of whom have an impact on the day-to-day lives of children and families that they serve. And we'll talk more about that in a minute. I just want to briefly share for everybody our session goals today, and to really echo the fact that we are going to be focusing on the commonalities across these fields and how identifying those can help us move towards system-level reform to really support these workforces that have very similar challenges, even though their day-to-day experiences can be so different. This is a presentation about a larger paper that Amber Posey and myself published late last year. It's on our website, Early Childhood Workforce. There's going to be several more sessions and blogs really talking about this content. I can't stress enough that this is what we hope is a first step in broadening this conversation. Even in the 30-page paper, we can't talk about all the issues that we want to. This is not comprehensive. It's a stepping stone. So who is a member of the early childhood workforce? I teased that a little bit for you on the last slide. In our work today, in this presentation, when we say early childhood workforce, we're referring to a broad range of professionals who work with young children and their families across education and care, health, child welfare, and more. Primarily, we're focused on ages 0 to 8. First of all, that's ICS's mission is to focus on that age group. In addition to, we also know that age 8 is right at that shift where early elementary school turns into elementary. And so trying to focus on those younger child outcomes and programming. Of course, many of these professionals are not limited by child's age. Pediatric medical providers can see children up to their adulthood through adolescence. Some of these folks focus more on infants and toddlers, but just to give some broad framework around. Like I said, we could not have gotten to all of the topics that we wanted to in this paper or in this presentation. I want to specifically identify that we're not talking today about first professionals, though early childhood wellness starts prenatally, and so those professionals need to be a part of this conversation moving forward. Doulas, midwives, OBGYNs. We also don't really talk very much about community-based providers. And that's partly from a lack of literature. If you want to be grounded in the research, you need to go where the research is. We're not talking today about librarians, coaches, clergy, all of whom we know can make a huge impact positively on the lives of families. So again, consider today a stepping stone, and we hope that it helps us all to think a little differently about these workforce issues that have traditionally been quite siloed. And that's really why we're bringing this cross-sector perspective into the conversation today, is avoiding those professional silos. Silo is kind of a dirty word in the field, right? We want to break out of the silos. We want Head Start and childcare to talk to each other. They're sometimes necessary, right? Programs can't be administered if every program is trying to do everything at once. The silos might be necessary for funding and operations, for licensure. But these professionals are serving the same families in the same communities. Just at different parts of their experience, early care and education and pediatric health. You know, they're working with the same families, child welfare. Those kids are within our communities. And so anything that impacts one part of that workforce working with children impacts those children and impacts all of those workforces. I don't know if it's a domino or if it's sort of a solar system here, but they're all connected amongst each other. One of the questions that we sort of got when we brought up this ecosystem perspective is, you know, a child care provider with an associate's degree making near poverty level wages, they need this conversation to talk about the workforce. But why combine them in the same conversation as a pediatrician with a medical degree who is making significantly more, what many of us would consider a very comfortable salary? Because at the end of the day, when you sit down and compare these folks to their adult or older children serving peers, they're facing very similar issues. They're undercompensated compared to their similarly qualified peers who serve different ages. And the burnout levels, the emotional toll of this work, and frankly, the way that COVID has impacted their work is all pretty significant. Today's conversation has to, of course, take COVID into account. But many of these issues well predate our current crisis. So at this point, I'm going to hand the presentation over to my colleague, Amber, who's going to talk about the 4 key themes that emerged in doing this work. Amber?
Okay, so the 4 main areas of concern we're focusing on today are compensation, burnout, safety, and retention. Next slide, please. Okay, so the first is compensation. This is an issue we're all familiar with on some level. It's widely understood nowadays that professionals in the early childhood space are often underpaid, and specifically they're underpaid in comparison to the rising cost of living, the difficulty of their work, and the size of their workload. So when we say they're underpaid, that does not just mean their paychecks are too small. While that is true, they also lack supplemental forms of compensation in the way of health benefits, reasonable vacation and sick time, and maternity or paternity leave, all of which are things that provide the workforce with a high quality and healthy work-life balance. So when these 2 needs are unmet, those needs being adequate pay and access to benefits, the outcomes, which you can see listed at the bottom of this slide, they're all things that threaten the quality of care children and families receive. Next slide, please. Okay, so here we're looking at the median salaries for some careers focused on children, and then some that are focused on adults or the general public. So these are numbers pulled from the Bureau of Labor Statistics, and you can see here professionals focused on children tend to have lower salaries than their counterparts. In addition, professionals in education who work for school systems make a good deal more than those who work in private centers like daycares. According to the 2022 poverty guidelines for the 48 contiguous states and the District of Columbia, the household income for a family of 4 must be $27,750 a year to be considered at or above the poverty line. So when we look at the education professionals in this chart, you can see one of them falls below that line and several others are very near to it. And remember, even if we're looking at a dual income family here, that number is the threshold. So while it technically should sustain a family of 4, it's unlikely to do so when taking things like insurance and debt, health emergencies, cost of school trips, etc., all of those things into account, which are very likely to befall an American family at one point or another. Next slide. compensation and churn. So here we're looking at the decisions an early childhood professional faces when they aren't offered adequate compensation. The two options that we're going to explore are changing employer and changing industries. Now, currently, due to COVID-19 and the staffing shortage affecting all industries, teachers, medical professionals, social workers, everyone has a higher chance of finding an alternate employer if they're interested. There are a lot of jobs out there right now, and that feels like a safety net for people looking to make a change. However, while it is an option now more than ever, the problem with leaving one employer for another, where you're essentially doing the same kind of work, is that a lot of those same issues that drove you to quit in the first place still exist. So it's because of this, many people in the early childhood sphere are choosing to leave the industry altogether. And that can mean quitting their job to get a new job, like in the restaurant industry, where maybe more personal time is offered or higher pay through tips. It could also mean choosing to retire a few years earlier than planned. So this phenomenon is happening industry-wide and at all levels of care. And one of the greatest contributors to this churn is the topic of our next slide. And that is burnout. Okay. According to the Mayo Clinic, burnout is a state of physical or emotional exhaustion that also involves a sense of reduced accomplishment and a loss of personal identity. So this is probably the term you've heard most often associated with the current state of the early childhood workforce. In fact, you may have already attended a presentation or two specifically about burnout and how pervasive it is. And that's because it's a major concern for the health of the workforce. In the context of our work and the mission of ICS, which is focused on the success of all children, the health of the childhood workforce directly impacts the health of the children it serves. So we'd hope it goes without saying, but burnout is an important issue and it deserves the attention it's receiving. You can see here in this list some of the physical manifestations of burnout, which are pretty serious, including heart disease, poor mental health, and substance abuse. And it's interesting to think of burnout being linked to such chronic issues of the body, because often when talking about feeling burnt out, it seems like the most common advice you get is to take a vacation, right? It's like maybe you're just tired or you just need some time away from this place so you can come back with a fresh mind and you'll be fine. But in reality, vacation or time off, especially if it's taken after you've been dealing with burnout for months or years even, it may not actually be enough. And I'll even go so far as to say it is not enough. And no vacation can undo the more serious health issues associated with long-term burnout. Really, we have to start thinking of burnout from a preventative vantage point rather than a reactive one. Next slide. Okay, so we have a few percentages that back up the previous slide and show a significant portion across the spectrum of the early childhood workforce that is deeply impacted by burnout. These numbers, they're just another reason we have to keep having this conversation and looking for opportunities and solutions around burnout, which we'll get to a little later in this presentation. All right, next slide. Okay, so this question, which came first, the chicken or the egg? So let's think about that in regard to burnout and stress. So stressors at work are certainly linked to experiencing burnout. Burnout can also increase or create new stressors at work. So in researching for this paper on the early childhood workforce, I came across an article that examined the experience of Black psychiatrists in America during the COVID-19 pandemic. And from the jump, caseloads have been high for mental health specialists, as many people are dealing with feelings of depression and isolation and grief as a result of loss through COVID-19. So because of this onslaught of mental health struggles, there are too many patients who need critical care all of a sudden, and there are not enough professionals. So in this article was what was unique for the Black psychiatrists is that most of their new patient requests come from Black community members who prefer talking to someone who can empathize with their experience. And it's important to note, psychiatric professionals in America are predominantly white. According to the APA, only 2% of American psychiatrists are Black. So that means the Black patients who want help from a Black psychiatrist, they have an even smaller pool of professionals available to them. That also means that those professionals have the potential to take on an insurmountable caseload. So with that in mind, these professionals dealing with the growing number of cases could certainly find themselves feeling burnt out as a result. But if they were already feeling burnt out before the pandemic, and I believe there's a strong case for that ringing true in the mental health community, the weight of that growing caseload, as well as the pressure to provide a service that is in rare supply to a group with greater need, could certainly become overwhelming and could certainly lead to a worsened level of stress than the one that initiated the burnout. At the end of the day, we believe the two are intrinsically linked and cyclical, and to improve in one area would be an improvement in the other. Next slide. Okay, safety. So when talking about safety, it's important we remember not just the physical well-being of workers, but also their mental and emotional well-being. On the physical side, many organizations have measures in place to protect staff from physical harm, excuse me, like tornado drills, de-escalation tactics, and in some spaces, vaccinations. The pandemic, however, has taught us that even though those measures are not enough to cover physical, they're not enough to cover physical safety. We saw that in the lack of PPE availability for many schools, daycares, and hospitals at the start of the pandemic. Additionally, many employers weren't prepared for major staffing shortages brought on by employees getting sick en masse, excuse me, which meant professionals who weren't sick had to take on twice the workload and in some cases twice the exposure. Mental health is a tougher nut to crack because historically it hasn't been treated with the same level of importance as physical safety. Some ways to shift the focus to good mental health include better health care that includes counseling services, and on a broader level, campaigns and actions that help to destigmatize mental health issues that arise out of the working environment. I do want to note here the asterisk we have next to stress relieving exercises. Okay, so we've got it listed under physical stress, physical safety, because stress can manifest itself in physical ways like headaches and exhaustion. It can just as easily be included under emotional safety. More importantly, it's a shallow solution that is not necessary, that is necessary, but it's not sufficient enough. There are systems level issues that require attention, and too often, policymakers and employers focus on individual level band-aids. This in turn puts the onus on the workforce to fix a problem they did not create and they do not have the bandwidth or ability to fix. I won't spend too much time on this one, but it does give a helpful breakdown of some common ways in which early childhood professionals in 3 different sectors all experience elevated threat levels where their safety is concerned. I also find it telling that most of these examples listed are focused on physical threats, but they are also rooted in mental health struggles. For instance, under pediatric health, a patient attacks a staff at a pediatric hospital out of fear, stress, or anger. So this is an incident that involves the heightened emotional state of both the patient and the staff, and then results in a physical altercation. So emotional safety can inform physical safety as well as the reverse. Next slide. Okay, so we've already identified the issue of safety. Now we need to understand the barriers to improving safety measures for our workforce. The physical strengths are important, but truly they are results of the systemic issues, which are usually rooted in poor communication and cooperation amongst policymakers, community leaders, and employers, as well as, and this is an important note to stress, inequitable access to aid in the broader population along racial, ethnic, and socioeconomic lines. Next slide. Okay, so retention. Finally, we get to the issue of retention, which should go without saying, but it is of particular importance because children require, deserve, and do better when they receive high quality services and consistency among those services. So we've already discussed this a bit under compensation, but when you look at the collective pot of issues being compensation, burnout, and safety, high turnover rates in the workforce really aren't that surprising. COVID-19 has only worsened this issue of retention to crisis levels. That's why we're hearing so often in the news that big business and small businesses alike are all struggling to keep staff or to stay open or to manage the same workload they deemed manageable prior to the pandemic. Although, as is implied throughout our paper, pre-pandemic workloads really were not manageable at all. They were just more manageable than they are now. Next slide. Here we've got a few examples of how significant of an issue retention is in various early childhood spaces. It is interesting to know here, we do not have any numbers on healthcare in this slide, and that is because those numbers are rapidly changing. According to the American Association of Critical Care Nurses, 2/3 of nurses surveyed said their experiences during the pandemic have prompted them to consider leaving the field. 21% of those polled in a study for the American Nurses Foundation said they plan to resign in the next 6 months. So those are pretty harrowing responses, especially when we think of how significant a role the healthcare system plays during a global health crisis. Okay, so with that, I'm going to turn the slides back over to Megan so she can give us back a little hope as we discuss opportunities to make positive changes around these 4 issues we've discussed.
Of course, coming out of today's conversation, we don't want to be focused solely on what the problems are. We want to empower folks to think about solutions. And so really high level here, we came up with 2 categories of solutions that are grounded in research, policy level changes and employer level changes. We really strongly felt that we needed to avoid things like self-care for the individual because these are system level problems and they cannot have individual level solutions. For the sake of time today, we're not going to walk hand in hand through each of these. We'll touch on these things briefly. Again, there's a more full discussion in our paper. Many of the solutions, we had to, again, go where the literature took us. There's much more research on the early care and education professionals workforce and the medical provider workforce. But after the themes that we've identified, we really feel that what we learn from one can really significantly echo the other. Now, as you can see from this graphic here, increasing compensation has benefits well beyond the individual professional that we're talking about here. In particular, when we think about the early childhood education and care workforce, research out of Berkeley shows us that many of those providers are themselves utilizing social welfare benefits like Medicaid and food stamps, and by increasing their salaries across the board, we can actually sort of rebalance some of the books on social service spending by not having those families and those workers be dependent on those services, which of course they're entitled to. And so I want us to really be thinking broadly here about increasing compensation as a good, not just for an individual worker, but for the whole system and for the families they serve. How do we do this? I would love to tell you that there's a big bucket of money and we're going to be able to use it to increase salaries across the board. But this is where the silos really do come back into play. Each of these fields is financed very differently. Healthcare services in this country are essentially fee-for-service, whether that's through Medicaid or private insurance. Child care can depend on grant funding, there's Head Start funding. We could be talking about state-funded preschool streams. Everything's a little bit different, and so there's no magic wand for this. But a few things to start our discussion here. The most important is we cannot increase compensation through rate increases for services. It cannot be done. The math does not work. There's plenty of calculators out there to show us that. And families who are receiving these services are already bearing a heavy burden. Nationally, parents spend about 10% of their annual income on childcare, and families with health insurance, for example, pay $22,000 per year on average in premiums, to say nothing of then the out-of-pocket costs for deductibles, et cetera. And so we cannot get to fair, equitable compensation for well-qualified professionals, which they deserve, on the backs of families. It needs to be systemic investment from government, perhaps philanthropy, and revisiting some of the ways that we do business as usual. And so the first thing that we want to present here is adjustments to existing financial streams. When we feel that wholesale change in the sectors are not right around the corner, let's start with what we can change more easily. Some of these include things like adjusting child care funding formulas by sending a higher per child rate to child care centers that fit targeted needs. For example, rural communities with a low number of seats, quote unquote child care deserts, for example, or infant and toddler seats where we have not nearly enough seats to meet demand. We can help increase the funding through formulas for those seats to allow those centers to compensate competitively the professionals that they need. That can help stem some of that turnover, bring in qualified professionals who provide the services that families need. When we look at Medicaid, for example, and then private insurance, which of course is more complicated, but Medicaid, which there are government opportunities to change, when you increase provider rates for pediatricians, studies have shown us more pediatricians participate. The reason that folks don't participate now is because they feel that the rates are too low for the services that are paid. Essentially, their staff aren't being compensated enough for that work. By increasing those rates, increase the size of a provider network, which is good for families. You can increase the compensation for medical staff and their office staff, and that in turn can reduce the burnout that we see happening in the field and increase retention. Nobody wants to have to switch pediatricians every 3 years because their provider has left the field or gone to another setting where they can make more money. And so thinking about what we can already do with what's in front of us is a really important strategy for where we are now. We also want to talk a little bit about wage supplementation. Wage supplementation, some of these programs that can help provide an extra $500, $1,500 a year to providers, they are not the end-all be-all. They are necessary but not sufficient. I want to make that clear. But in the meantime, there's good research that shows us that these programs really can potentially stop the bleeding of providers leaving the field. Some of the emergency funds that were provided during COVID, whether through the Paycheck Protection Program or how states chose to allocate those funds, hazard pay, that can help to keep providers during a crisis time of very high need. We also know that the Wages Program, which is focused on child care providers, can do a great job of reducing year-to-year turnover and keep those providers. It's very structured. It's based on qualifications and time in the classroom and setting type. It's not a surprise, and there's a predictability to it. And from there, you can also build a scaffold to further professionalize the field and really bring people, continue to develop their skills and bring them along. So much more that can be said about compensation, but for the sake of time, we're also going to talk about the need to prepare for growth. Now, according to the U.S. Labor Bureau, from 2020 to 2030, overall, the U.S. workforce is expected to increase in size by about 8%. So the number of jobs we have now is going to increase by about 8%. But the fields that we're talking about, social work, early care and education, mental health, child health, are going to increase significantly more. Social work, 12%, early care and education, 18%. Some of that is actual need and really realizing that need. Mental health professionals stated that they've seen over a 30% growth in services demand in the last year to 2 years due to COVID. So some of this is changing circumstances. Some of this is when the government finally makes money available for some of these services, as we've seen states and federal governments doing, there are more opportunities for creating those positions. Current turnover rates combined with this need for growth is really going to create a mismatch here. We're going to have much higher demand for these positions and demand for these services than our current workforce is allowing. Now, this is great news for those of us who work in the field and really want to see services expanded to the benefits of children and families. But, what can we do to be ready for this growth? First of all, focusing on how the workforce operates now is huge. You want to prepare a place for students who are in, higher ed programs now to go and to be happy and to stay. And so working on things like increasing compensation now, not just for new hires, but to show that a workforce, can support their career long term. That's going to encourage more people to go into these fields if they believe they can make a stable and rewarding living in those fields. Initiatives to reduce burnout and to show that you're not just dealing with this emotional labor on your own. It's also a good way not just to shore up the field now to reduce that retention, but to help create a place that people want to go to for their careers, to bring their passion and their knowledge. In the meantime, while we think about those very big picture issues, maybe there's some low-hanging fruit, and low-hanging fruit is still delicious. So let's start there. States and municipalities should look into licensing requirements. Are they making it easy for a provider who's moving from one state to another to transfer their license? Are there fees that are getting in their way? Is there a bureaucratic process that's slowing that down? That in upon itself won't fill this whole gap. But if there are providers coming into a community, let's make sure that they are able to work for their highest and best use. Let's make sure also where we have Medicaid funding options or in programs with government reimbursement that providers are able to work sort of to the top of their license, to the top of their credential. Anecdotally, I've heard from mental health folks that many folks with a bachelor's in social work degree, there's a lot that they could be bringing into that workforce if there were more beneficial reimbursement policies to allow them to provide more of the services that they're qualified to serve. This does not mean remove all restrictions and let folks run free. It does mean just creating smart policies to support the workforce of today and the workforce of the future and keep growing that. Higher education is also going to be a key piece of this, and so all of us in the field need to be thinking about how we can work in partnership with 4-year programs and 2-year programs to really make sure that students are seeing a path forward here and that degree programs are going to be producing enough of the professionals that we need. Some of this is revisiting some of the assumptions that we've had. Maybe for something like care coordination and navigation, a 2-year degree is a wonderful fit here, and it doesn't have to be a 4-year degree, as long as we're talking about a skill set that aligns with the qualifications, that aligns with the salary. Looking at things like loan forgiveness and scholarship programs as credentials increase, right? We hear this in nursing a lot, that it used to be that an RN is enough, and now a lot of places really want the bachelor's of nursing. How do we get folks back into school to obtain those degrees so they stay in the field and keep that wonderful expertise they've developed over time, which can help foster new life into the field? And just to show you very quickly here this graphic about the growth in child psychiatry. As it is now, the American Academy of Child and Adolescent Psychiatry recommends 47 child psychiatrists for every 100,000 potential patients chosen in the area. Right now, in the U.S., there's an average of 9.75, which is hugely deficient to what's recommended. 70% of counties have absolutely no access to a child psychiatrist, and even fewer of them have expertise in infant and toddler mental health, which is increasingly recognized for its importance these days. And so, into thinking about the growth in the field, we need to really look at where these shortages are now and target efforts there. Make this an attractive field for folks to join so that the number of professionals in the field meets the very clear demand for services. The final piece that we're going to just talk about here to put a bug in everyone's ear is the need for data-driven decision-making. This paper was only possible because of streams of academic research done by researchers interested in workforce issues and professional associations, several of which we've included their logos here because their work has just been so phenomenal. They do reports on their staff. They do surveys to understand what providers in the field are facing as challenges. Several of them have fielded surveys, even during COVID, to understand how that crisis is affecting their providers. Extremely helpful, but we need more. And I know that when we're talking about huge issues that involve big costs of increasing compensation, more money into data, it can feel, isn't money well spent? Yes. We need to know where we're going before we get into the driver's seat. We need to know how demographics come into play here, especially for providers who have been traditionally underrepresented or undercompensated in some of these. We need to know about geographic distribution, where the differences are city, suburb, rural, state by state. National numbers are not enough when we're talking about serving children because these are face-to-face roles for the most part. So, of course, we do talk about the virtual aspect in this conversation. And so continuing to support data collection and data-driven decision-making at the government level, at the philanthropic level, and for those of us who are involved in data collection and analysis, making sure that we're seeing this ecosystem perspective and trying to work to connect our data. I want to be able to tell you the story of what's happening in child life and pediatric nursing and not have to tell you two different stories. And right now it's difficult to bridge that data. And so continuing to keep that conversation on, knowing where we are to help get the field to where it needs to go. And Amber's now going to close us out by taking us through a conversation about employer level changes. Amber?
So employer level change, creating conditions to avoid burnout. Self-care, it's been a huge topic of discussion for years now. There's the idea that taking a bath or going hiking or treating yourself to comfort food is a form of self-care, which is true enough. But I would argue it's a small step towards truly feeling rested and healthy. And at the end of the day, a lot of the things we're combating and doing small acts of kindness for ourselves are too big to be fixed by calming exercises. These issues will persist. Interestingly enough, the effectiveness of self-care, it really relies on the culture of care created by others. If you work for an employer who respects your need for self-care, let's say they encourage you to take personal time for your kids or your birthday, or they support your interest in working remotely at a task that doesn't require you to be in person, then you will reap the benefits of those acts focused on making your experience more manageable. Employers also benefit from this culture shift, as workers tend to be more focused and productive when they find their job satisfying and fulfilling. Sometimes avoiding burnout is as simple as feeling respected and valued at work, and that kind of affirmation is best served from organizational leadership. Next slide. Cycle of burnout. We somewhat discussed this cycle earlier, but it's a great graphic to show the levels one goes through, jumping back and forth between feeling burnt out and then trying to attend to your own burnout as an individual. There's the cultural implication behind it all, which is that modern society values a high work ethic and team members who deny their individual needs for the good of the whole. So this is a cycle we're trying to break. And again, the best way to do that is by retraining that way of thinking. In reality, meeting the individual employee's need for self-care has implications and benefits for the system as a whole. Next slide. Okay, peer support. So peer support is all about building community and strength through that sense of community. The benefits here are great. As you can see, it creates comfort in having shared familiarity and not being alone in facing a challenge. You also get deeper understanding from a peer than you might from somebody outside of the workspace, who maybe can offer an ear or a kind word, but can't fully understand the depth of your experience. This also holds weight for those situations at work that maybe are confidential and cannot be shared with outsiders. So it's a simple one, peer support, but an important one to mention. Next slide, please. Okay, embracing virtual opportunities, which is what we're doing here. So we've got a list, we've listed for some benefits that virtual opportunities have brought specifically to the child welfare space. Those being increased engagement of families, a reduction of transportation time and stress, and an additional reduction in stress that comes from having visitors in your family's home. So we want to, here we want to acknowledge that not all visits can or should go virtual. There are some benefits in being with families in person that just cannot be replaced by a virtual call. But virtual meetings are not recommended as a replacement of services. Rather, they're recommended as an add-on that can relieve some of the barriers to families receiving quality care. There's also some room for improvement in our new world of digital meetings, and that is probably most apparent in looking at telemedicine. So while a lot of people benefited from having health visits with medical professionals online during days in the pandemic when maybe going into a hospital or an office felt unsafe due to risk of high transmission or high risk of transmission. It also proved to be an inequitable option as families without access to broadband or those in more rural parts of town where internet strength isn't at its best. Virtual visits to the doctor wasn't an option for them. Additionally, there's an issue of insurance companies covering telehealth. There's been really a roller coaster of coverage offerings from the start of the pandemic to now, and that's ever shifting. So if this is going to be a long-lasting benefit to families in need of medical advice who are unable to access it in person, it really has to be strengthened so that it can benefit all families across the board. Okay, next slide. Okay, so professional development. When we say professional development is a helpful tool to combat those four main issues, really we're suggesting meaningful professional development. So we've all been to like a lunch and learn that feels like a passive opportunity to check off a box maybe. Maybe we go into it interested in the topic, but we aren't taking home the tools being taught and incorporating them into our own work. So we suggest employers make the effort to find more meaningful sources of PD for their team, opportunities where employees can feel engaged and excited even. Of course, with that suggestion, it includes the basic requirement that these opportunities be equitable and accessible to all employees interested in pursuing them. Next slide. Okay, easy one. Safety considerations. So lastly, employers should develop protocols, encourage employees to express safety concerns, and enhance their system for training employees on how to deal with safety concerns in the workplace. All right, so that brings us to the end of our presentation and the start of our Q&A session.
Great, thank you, Amber. Folks can feel free to submit their questions through the chat box or through the Q&A protocol. Our goal here was to really leave a good chunk of time, and we have that now, about 15 minutes, to answer any specific questions. This topic is large, the paper is large, and what we wanted to do today was give a little sampling of some of the elements that we addressed, but we can't necessarily go deep on all of those. That would exceed an hour for sure. What we really wanted to do today was to introduce this framework that we need to stop considering these professions solely as their individual professions. Cross-sector collaboration is not just for a once in a while grant application. And we truly believe that, borrowing maybe a little bit of inspiration from the collective impact movement in the nonprofit world, we can advocate for more change in these sectors collaboratively. The idea that pediatricians and childcare providers both had many of the same pediatric struggles, especially early in the pandemic, we were finding similar rates of not having access to face masks, for example. These might be two professions that previously have not seen themselves collaborating on a lot of advocacy, but moving forward, there's a lot of potential for that. While we wait for some questions to come in, there's a couple of things that I want to touch on about what do we do next with this paper. As we said in the beginning, we released it in December of last year, and now that it's out there, we're going to keep talking about it. We're going to be doing a series of blogs, a few other conference presentations as well, to talk about more of the specific issues that are here. There's also a chance to dig in deeper on some of these issues. One of the things that we want to do for sure is to circle back in on some of the professions that are not included in the paper, in particular birth professionals, OBGYNs, midwives, doulas, home visitors, focusing on the prenatal period, were not included in this study, in this report, just because it was a whole other sector of literature to get into, and some of the way the reimbursements work a little bit different. But health and child well-being, they start prenatally, and so we want our work to align back to that. As Amber mentioned, and as some of you may have discussed in one of our morning sessions as well, telehealth home visiting, everything. That's an area that we really want to dig deeper into. I'm a researcher, but I'm also a parent, right? And so things like having virtual parent teacher night, it's made it easier to be in touch with our child's teacher. Does that mean that that's going to work for everybody? No. And so how can we help folks take a measured approach towards virtual services moving forward, even when we do feel that it's safe to be in large groups again? Even when we think about this conference, hybrid is great, in person is great, virtual is great. How can we really, utilize and optimize with the help of, teleconnection services? The broadband and accessibility challenges that Amber mentioned are huge. It is great for convenience, right? One of the things that we learned, even for quality of life, was that for child welfare professionals, they know that they can't, do home visits, that all of the home visits that need to be done via a Zoom. That just doesn't work. It's not appropriate in child welfare services. But staff meetings maybe can be moved virtual. And those are professionals who spend a lot of time going from place to place. And by reducing some of that travel time to get to their office, we heard this from physicians too in the research about weekly team meetings and that type of thing. People really value their time. We all should value our time. And so not just thinking about the sort of clinical implications of teleservices, but also the workforce implications there. And the third topic that we want to dig a little bit further into here is the really complex interplay of race and gender in these fields. All of the fields that we discussed today are female dominated. There is some good literature to suggest that that is part of why they are undercompensated and underinvested in. Historically, in the U.S., we have not seen care work as valuable as, factory work or other types of work. And so this really continues that tradition. Even in these female-dominated fields, like pediatric medicine, which is pediatrics and OB are the most female-dominated fields in medicine. There's a huge pay differential on average between the male providers making, $50,000 more than the female practitioners in female dominated fields. Then when we turn to the racial aspect here, childcare providers are overwhelmingly women of color. And so when we undercompensate those workers who do work of tremendous value for our children, we are continuing to underinvest, not just in care work, but in communities of color and female-led households. And so there's a lot of historical trends that feed into this, but COVID has really been a very cold bucket of water on a lot of our systems that haven't been working for a long time, but finally gave us the wake-up call to pay attention to those. And so I am optimistic that if we're looking for change, now is the time to make that change. So stepping off my soapbox, let's take a look at the Q&A here. We have one comment that says, one of the issues we are currently trying to find a solution for is health insurance for our child care providers. Is there anyone who has found a state-funded solution besides Medicaid? So I will first say that Medicaid is an option that should be considered. And I would ask that people not throw rocks or tomatoes at me because I know that that gets into hot button politics. We talk a little bit in the paper about some opportunities, not just for broad Medicaid reform, but for more tailored Medicaid reform. There are some states who have put in waivers specifically to focus on certain nonprofit employers to grant Medicaid eligibility to providers in those fields, identifying that there is a real need for that care and that you can sort of create this carve out. And as Jessica has just responded in the chat, this is my next plug here. So shared services is a really remarkable model. And Palmetto Shared Services in particular works for childcare providers in South Carolina. And if that is your field, please do check them out. In other fields, there are shared services in other states. It has really taken off in the childcare field because so often there is this lack of benefits. But there are sort of associations in other areas as well. When you look at things like early intervention services, where you have a lot of individual contractors, you might also find opportunities there for a shared services alliance. Basically, what that means is it is employers coming together under an existing structural umbrella of Palmetto Shared Services in this situation. And shared services uses that buying power of then having a group to access things like bulk discounts on supplies to health insurance, those types of things. And so all of the benefits that I get by virtue of being an employer who can access group plans, Palmetto Shared Services and other shared services models, can help to do that. Shared services models are also hugely beneficial when we think about professional development. It's a great way because they have members to really tailor professional development to what is needed. And that's something that, Amber had discussed here. We have a Q&A here also as well. As the pandemic becomes, quote, the new normal, are we seeing that professionals who left the field are staying out? Do we have a sense for how many are returning now that it is safer than it was a year ago, or have they stayed away? This is a great question. The employment data are changing so quickly. I would say quarter by quarter, it's a different story. Because these are heavily female-dominated workforces in particular, we heard through a couple studies and certainly through some anecdotal and qualitative data that for some folks, the reasons that they left were related to childcare demands, taking care of their own children and keeping their children safe from contracting the virus. So what you might see is, say, an emergency medicine pediatrician who left their position, or a pediatric nurse who left their position because one, the burnout, and two, the very real risk of contracting COVID and bringing it home, pre-vaccination when that wasn't an option yet, they may have stepped out of the workforce. Their kids were being virtually schooled. They had to be home. The job was too risky. Now they've been out of the workforce for a while. They may be returning, but not in the same place, right? They're certainly not going back to that same position because that position's either been replaced or is not being funded because hospitals are making cutbacks. Maybe they're going to do travel nursing. Maybe they're going to work at a private practice instead, or school nursing. One of the interesting things that we had identified in the paper is that school nursing used to be seen by the numbers as a place that people would leave, right? You started in school nursing and then realized that you could make a lot more money in hospital-based nursing and still work with kids. And so there was really this pipeline from school nursing to hospital nursing. But now you're seeing a little bit flow back as well, because school nurses, the need for them has just really exploded with health screenings and the need to take COVID seriously. A lot of districts have brought on more nurses where maybe they had less than one nurse on average per school before. And so these are folks who might be saying, well, yes, the pay is less, but the hours align with what I need because I can't find childcare, or it reduces my risk of contracting COVID and bringing it home to my family. And so that's not an answer to the employment question, because it's such an ebb and flow right now. And the way that a change in one sector impacts the other sectors, it's a really dynamic situation right now. I don't think we'll have a really clear sense of how these sectors have been impacted until, I would say, at least another year from now. Okay, I have a couple of questions coming in here. So one person says, not really a question, but we've been struggling to keep teachers who build their professional credentials and then they move to the public schools. It's tough because we really support them getting their degrees. It feels like we're working very hard and don't benefit from it. First of all, just some validation for whoever sent that in, that you are not alone. And I don't know that that's comforting, but this is a challenge that we heard in several fields. We heard this as well in social services, in particular, that a lot of maybe social workers will come out of school and they need supervised hours before they can be fully licensed. And so to get that supervision, they will take on these lower paying jobs in certain home visiting programs and child welfare programs. Just have a really tough 2 years, right? The emotionally exhausting work of being a part of the child welfare service sector. And then once they've gotten their supervised hours, they leave, or they go into supervision, which has a lot more money, for them to get as well. And so hearing also from childcare providers, you help support your providers getting a higher credential and then they leave. A lot of programs that help to do this, whether through stipends or scholarships, they do have a payback clause that if you leave before, 3 years of employment, once we've helped you get your degree, you do have to pay it back, or there's additional interest or something like that. Right now, that is sort of the best mechanism that folks have to keep providers in those places. But at the end of the day, it also comes back to the bigger structural issues here. And I don't want it to sound like we're blaming any individual childcare provider here, but if the field was then able to compensate those providers like they were a public school teacher, they wouldn't be leaving for the public schools. They would be satisfied in the work that they're doing there with a population that they apparently care about, because I don't care who you are, you can't work in childcare for 3 years if you don't like kids, because that it's an uphill battle every day then. And so at the individual level, at the employer level, we can think about creating those programs and creating those mechanisms to try to keep the providers there after getting their degree. But this is where we also now segue into the policy solutions of pushing for more and more funding where we need it, to help increase the capacity of programs and the ability to compensate those providers, appropriately to keep them there. Right, and another one over here. Sorry, my cursor just kind of jumped all over the place. Do you know of any initiatives at state or federal level that might increase provider compensation in some of our early care systems if the providers demonstrate that they are using evidence-based, I got cut off there, evidence-based processes for care? So generally what happens with most early care funded programs is we tell you what model to use and you use it. We might give you money to do it. We might give you sort of, support to do it, but rarely, to answer this question, you do not see a lot of funding structures that say, if you move from sort of this curriculum model that you're doing to this one that has a greater evidence base, you will get higher compensation. What you do have a lot more of in early care and education are tiered quality rating and improvement systems, where the provider can get a higher reimbursement rate from the state for providing childcare for each child if they meet certain thresholds. And those are often not directly linked to the way the service is offered. It's not saying switch to an evidence-based model. It is saying, improving your quality, your measure on class, your ratio, those types of things. We do see some interesting work. For those who don't know, ICS also does a lot of work in the outcomes-based financing world. We have seen some interesting work, especially in Connecticut, where they're using something called a rate card approach. This is specific to home visiting programs there, where the reimbursement rate that you can get is higher based on documented achievement of certain outcomes for children. It is only available to certain programs, all of which are evidence-based or informed. But generally speaking, the funding streams that we have for these models right now can be pretty prescriptive to begin with. And so if you are providing nurse family partnership home visiting, you are providing nurse family partnership home visiting, right? You don't get into a home visiting program by saying, we're going to do home visiting, and then sort of choosing which one. You go in there with a model already in mind. But the way that we think about bonuses and achievement pay, it needs to be revisited. But again, I'm going to bring us back to a wholesale, deeper investment in the field can help avoid some of that, so that any bonuses are really for exemplary care, and we can consider high quality to be just the basis for everybody. At this point, we only have 1 minute left in the session. Thank you, everybody, for joining this afternoon. Thank you for joining the conference. We know that you've had probably many virtual events over the last 2 years, and delighted that you made the time for ours. I'm going to just once again put the link for the SC Endeavors form in the chat box. And if you have questions about CMEs, you'll be getting paperwork in your inbox very soon about that. I'm happy to stay around for a few more minutes for a couple of other questions, but for those of us who are watching our time, the session is concluded, and thank you so much for spending your afternoon with us.